Welcome to a special episode today, which is titled Managing Iatrogenic Events. It is written by the Professor Yoshi Terushi. You will see that his writing is precise, informative. He uses a lot of explanatory illustrations. As always, I've written a summary at the end of the chapter, but it by no means will be sufficient to cover all the topics that the professor has spoken in this chapter. So I highly recommend you follow along and watch the full episode. Now let's start. What is a iatrogenic event? It is a procedure induced inadvertently by a physician or a surgeon, which means it's a mistake that happens when the physician is doing the endo treatment. To prevent as iatrogenic accidents as possible, we follow the 3 T's rule: training, technique, and technology. Starting up by the sodium hypochlorite accident. It is an experience that likely to leave the patient wary of both the procedure and the practitioner. When it happened, it damages the vital tissues. It initiates hemolysis and ulceration. It damages the endothelial and fibroblast cells, and it inhibits the neutrophil migration. And we can see its effect on the bone here in the B picture. It made demineralization of the bone. It's like a burn. It can be as severe as this situation. Let's discuss this one. This patient had this lateral incisor that had a post inside. They removed this post and made a non-surgical retreatment without doing a retrograde filling. After they wanted to put the post that they left, they irrigated the canal with hypochlorite. So because it is restricted at the end, the hypochlorite made a great diffusion in the periapical area, and the patient has lost its mastication ability to lift her upper lip and to smile properly, because the buccal branch of the facial nerve was affected. So she lost her cheek function and upper lip function as well. After 3 years, this picture is after 3 years after the accident, the weakness is clearly visible. So she did not recover after this accident, and it became permanent damage. So please be aware. And I don't know why they did the surgery if they removed the post. We do the surgery if we are not able to remove the post. So it's practice, to be honest. First, when this happens, we must reduce the pain by doing local anesthetics and to give the patient an analgesic, which is ibuprofen. Also use cold compresses to moderate the swelling and the edema. Then we do a copious amount of saline irrigation to encourage bleeding and to dilute the hypochlorite and remove it from the site of the injury. After 1 day, we use warm compresses to stimulate the local microcirculation. Antibiotics are usually prescribed to reduce any systemic symptoms, and it can range from being an oral medication to an intravenous, depending on the severity of the case. If there is increasing in the case, like swelling and impeding of the airway obstruction, it became an emergency situation, and it must go to a hospital. Actually, after this accident, the patient becomes highly anxiety, feeling anxiety, and they become they refuse to continue the procedure and the treatment. The second iatrogenic event is an instrument separation. Nickel titanium rotary instruments they tend to get separated higher than the hand instruments. The main reason is the malpractice, which means that, for example, inadequate access, overuse of the instrument, too much pressure. These can increase the rate of this accident. There are so many ways to retrieve the file, like the extractors, the wire loops, and post-removal systems, the ultrasonics. The author here shows us many techniques, and at the end of each dentist can follow techniques that he finds appropriate and easy. Let's start with the ultrasonics. They are so efficient removing the separated instruments. We place the tip of the ultrasonic between the exposed portion of the separated file and between the canal wall, and then we vibrate it in a counterclockwise direction around the file, applying an unscrewing force. Usually most of the this technique removes most of the files. Occasionally the file will suddenly exit out of the wall of the canal. We must take care not to put the tip of the ultrasonic directly on the separated file in order to prevent an accidentally extruded it into the bone outside the radicular area. Also, when we use high speed activation, we can separate the file into smaller fragments and will make the procedure harder. We should not exceed 45 to 60 minutes of trying to remove the file, because after that we will make the prognosis of the attempt less, because we will have an fatigue. The dentist will be tired. We will have an over enlargement of the canal. Also, we will increase the risk of the perforation, and the instruments that we are using will become fatigued also. When we do the attempts to remove, it must be in a dry condition in order to have a good vision where we are applying the force. After we have an unscrewing motion and the file starts to move, now we can use we can do the removal in a wet condition by using an edita as a lubricant, and use copious amounts of hypochlorite to get advantage of the cavitation when we do apply an acoustic power to it. Cavitation means that we are creating air bubbles that are applying a force when they are bursting, and they will enhance the cleaning effectively of the fluid. Also, it will help the file to get out of the canal. The motion is a pulsing in and out with the lowest possible power setting. Now, the first case of removing a broken file, when the instrument is visible to us. We first use a few drops of edita as a lubricant in the canal to facilitate the separation between the file and the canal wall. We remove the excess oil with a paper point. Then we insert the ultrasonic file, which has a spoon tip, and its concave portion is facing the separated file. This is the spoon ultrasonic tip. The concavity will face the file, the separated file, and the convexity is facing the canal wall. This is the 𝐏𝐻 retrieval kit. It has an modified 𝐏𝐻𝐬 and a trephine. This is the 𝐏𝐻𝐬, and this is the trephine micro trephine burr. This is the concave spoon-like ultrasonic tip, and this is another ultrasonic tip. This is the 𝐏𝐻𝐸 pin, the loop. After we insert the spoon-like ultrasonic tip between the space between the canal and the file, we do a 90 semicircle movement, which means a 1/4 move around the separated file. Then we insert the straight tip to expand the space to complete the 180-degree semicircular space on the inside curve. So we are creating space around the file. We do not exceed our interior more than 1/4 of the file length. We are only increasing the width around the circumference of it. First of all with the spoon tip, then with the straight one. Then we will feel that the separated file gets loosened. In some cases, if the file is not too long and we did enough space around it, it will most of the time get loosened and will get by itself out of the canal. An illustration that shows the steps of retrieving the file that we are seeing. Here we insert the ultrasonic tip at the inner wall of the canal. This is called the inner wall, and this is the outer wall. When we put it in the space and activate it, it will pull the instrument out. But if we put it in the inner wall, it will push it to the apical area. Also for this, we should now put the ultrasonic tip in relation to the separated file where there is no canal behind it. This may cause a secondary fracture of the separated file. We can see that the first portion of the file is usually the portion that it is stuck, and the rest of the file is usually loose. So when we are doing the retrieval, we are working on this portion, this place. If you do the appropriate loosening, most of the time all of the file will be out of the canal. After we do the mechanical preparation with the ultrasonic tips, if it did not come out by the ultrasonic strokes, it can, by the activation, by filling the canal with a data solution, and take advantage of the cavitation and the acoustic streaming effects of the instrument retrieval. And the activation occurs with this here, with the space that we have created by the preparation. Also, we must use the appropriate size of the ultrasonic tip, that it can fit probably to within 1/4 to 1/3 of the instrument length. This is the spoon tip that we do first a 90-degree preparation. Then we use a straight tip to do a 180 degree preparation. This preparation, if we is not sufficient, the 90 degree only, we can see that in these white arrows that the instrument is still uh, stuck within the walls of the canal. Now let's talk about retrieving the file when it is not visible. How do we do it? Which means that the braked instrument is in the second curvature of the canal, where here we cannot see. This is the extent of our vision, and the broken file is in this area. What we do is we rely on the sensation, the tactile sensation, by inserting the ultrasonic tip in also in the inner wall of the canal until we feel the catch between the file and the instrument. It must be thin and sharp, like the thin spoon-shaped tip or the sword-shaped tip. So we pre-curve the instrument and place it in the space between the gap until we feel the sticky feeling. When we feel it, we can do a radiograph to ensure that we are touching the broken instrument. Then the tip is activated to create a 90 degree semicircular space using a pecking and pulsing motions, using the lowest ultrasonic activation intensity. When the sticky feeling is lost from the ultrasonic tip, the root canal preparation for instrument retrieval can be considered complete, and then the instrument retrieval attempts should be made from this point. Here we do the preparation first, getting a narrow and sharp ultrasonic tip until we feel the stickiness. Then we do a 90 degree, the activation to create a 90 degree gap. We do so we go into, we complete the loosening around it until it is retrieved. This is the case that applied the technique that we have said, that they placed the ultrasonic tip in the gap between the inner wall and the separated file. Do some strokes and it was out. In cases where the separated file is loose and it is extended beyond the apical area, in this situation we need no preparation. The only thing that we need is to do an activated irrigation, where we do copious amount of irrigation that is activated, like this case. Here we can see that this file was out of the canal. Then we do when we did the activation, the negative pressure pulled the file inside the canal, and we did it another time until it was out of the canal, like this illustration. So these are rules to keep in mind. When the instrument is shorter than 3 millimeter and it is between 3.1 and 4.4 millimeter, we can estimate the length using a radiograph, or get the precise length using a specificity image. And the curvature is less than 30 degrees, the clinician will mostly be able to retrieve the file using an ultrasonics alone. The canal is rinsed with EDTA, and it eases the retrieval. After completing the preparation of the canal, when we are going to do the retrieval around the file, taking out the retrieving the file actually takes no more than 10 seconds. But when the separated file is longer than 4.5 millimeter or with the curvature greater than 30 degrees, the loop, which is the Yoshi loop, should be used to retrieve the separated instrument. Or if the file is not long but the curvature is more than 30 degrees, the loop here is useful to be used. The loop is 0.4 millimeter in width, which means that we need a space around the separated file that is 0.4 in order for the loop to be able to get in the place, and it needs 0.7 of length that is visible, that we can get the loop around it. When we do the catch between the loop and the file, we do various directions with a sewing motion to dislodge it from the canal walls. Now let's discuss the ledges. This is the ledge, which is an irregularity in the preparation of the surface of the root that inhibits the preparation file to reach to the apical apex. The reason is failure to pre-curve the instruments and forcing large files into the curved canals. So ledges are more probably happen in canals that are greater, that have a canal curvature that is higher than 30 degrees. We must first take a radiograph to confirm the ledge formation, which is considered as that the canal is usually straightened at the point where the file stops negotiating the curve, which means that we stop feeling the stickness and suddenly the file becomes loose in the canal with no more tactile sensation on the tip of the instrument binding in the canal. When the ledge formation is identified, the shortest file possible that can reach the working length should be selected to bypass the ledge, because it is more stiffness and allow the clinician fingers to be placed closer to the tip of the instrument, which provides great tactile sensation and more control over the instrumentation. It is usually requires determination, perseverance, and patience to bypass a ledge once it is formed. It's not an easy task. There are many ways that we can try bypassing a ledge. Starting up, we will discuss the hand instruments by pre-curving the. We first explore the ledge by pre-curving, for example, a headstone file, a 25 size. For the original pathway, introduce the irregularity over the ledge. So at first we enter these manuals to explore where is the ledge and to decrease the irregularity in this place. So here, if we did a preparation in this area and remove this area, we will get a straight access to the original canal path, and that's what we did here. And we can see that we retrieve to the original path. Then we do some preparation to make sure that the ledge has become one with the canal and will not interfere with the preparation. So we usually flare up the canal to get access to the original pathway by doing what is called an anti-curvature direction preparation. So if the preparation is in this area, the preparation must be in the opposite one, anti-curving it of the file, which must the curve of it must be in the opposite and considered to the ledge. This is another way to bypass the ledge. We first explore the area using hand instruments like these that are called the TFRK. These are, we insert them in short push and pull strokes to widen the area and to reduce the ledge curve. Here we are getting this explorer and inserting it in an up and down motions. This aid to confirm the ledge formation and take a radiograph. Then we start exploring it with the hand instrument and doing an up and down strokes to get to the original pathway and decrease the curve of the ledge. Then we use an orifice opener that is the rotary file one, which is pre-curved. It is taper 4 size 15. And we do it to increase to widen the original canal after we do a pre-curve to the file before we insert it. After that, we use a hand blue file, a hand rotary file, but it is used as a hand file, and the apical patency is established here. So we first do an negotiation with hand files like this. Then we reduce the curve and of the ledge. After that, we use an S1 rotary file to do a preparation to reduce the ledge. At the end, we gain the patency using an rotary file, the blue one, but using it manually. The reason that we are using a rotary file as a manual to get benefit of the elasticity that the rotary file has that they can get along the shape of the canal. Another method is using the K files. If we do not have the microscope, we pre-curve an 8 or 10 hand file using the rubber stopper with its directional indicator pointed in the direction of the original pathway when we are inserting the file, we are getting it in the right position. Then we do a slight rotation combined with a pecking motion until we feel that we are advancing the instrument to the full working length. If this technique was not successful, we do an enlargement to the canal, flaring it up. Then we reinsert the K file and pre-curve by doing a pre-curve to it. And it must be small to bypass the. Now let's talk about bypassing the ledge using an ultrasonic tip. We use thinner ultrasonic tip to enlarge the coronal portion of the original canal by pre-curving the tip in the direction of the original canal. After we insert it in the right direction, we do an activation in a short push and pull motions that will automatically enlarge the opening of the true canal in a few seconds. Once the orifice of the original pathway gets wide enough for file insertion, we insert a negotiation hand file to establish the patency and to smooth out the irregularities of the canal. Then we continue the preparation using an nickel titanium rotary files. We can use nickel titanium files to flare up the canal and the coronal to the lens formation before we bypass it. The final way in bypassing a lens is using a rotary instrumentation. We first do a coronal preparation to the lens to enhance the visualization of the lens. Then we pre-curve a file 2 to 3 millimeters from the radicular area. The rotation speed is 100 round per minute, or we can use 150 round per minute, but reciprocating between the 30 and 60 degree of motion in short and up and down motions, until as it is brought slowly into the canal and move radicularly. Once we fill the lens, we withdrawn about 1 millimeter the instrument up, and then we immediately reinserted it. This allows the pre-curved tip to move to a different orientation within the canal as it is reinserted, which means that as we feel this encounter, we are in the lens. So we withdrawn a 1 millimeter and reinserting it so that we are on the original path, and we are eliminating the lens by doing a preparation of the original path. We do it in sequence of the size of the rotary files. Here they are saying that if the rotary file is in a high speed, like 300, it will not go into the original path. But if we pre-curved a rotary file at 100 round per minute or 150 round per minute with a 90-degree clockwise and a 30-degree counterclockwise reciprocating motions, it will most likely get into the original pathway. So this is the secret recipe. 100 is the speed, and the reciprocal motion is 90 to 30 degrees. This will make the instrument to get out of the lens and go to the original path of the canal. Here is an experimental. This is the 300 speed, and this is the 100. And we can see that this get into the ledge, but this has bypassed it. It is recommended to use a non-cutting tip to reduce the ledge formation. Now let's discuss the radicular extrusion of the root canal filling. When the 𝐏𝐝𝐢𝐭𝐢𝐴 is extruded into the periradicular tissue, there can be a severe inflammatory reaction. However, the MTA and the bioceramics are biocompatible, and there is no need to remove them if they have extruded the area, the radicular area. How to retrieve a 𝐏𝐝𝐢𝐭𝐢𝐴 that is overextended into the periradicular space? Removal can be attempted by inserting a new headstone file using 15 or 20 size into the radicular obturation, using a gentle clockwise rotation to a depth of 0.5 to 1 millimeter beyond the radicular constriction. The file is then slowly and firmly withdrawn with no rotation, thereby engaging and removing the overextended material. Here the writer is showing us that when MTA has extruded from the canal, it did not cause an inflammatory response, and after doing the follow-up, we have seen that healing had occurred. On the contrary, here when an 𝐏𝐚𝐿𝐴 portion of the file, 𝐏𝐚𝐵 was extruded of the canal was filled with an MTA, so we got a partial healing here, but this extruded part of the 𝐏𝐚𝐵 has a consistent inflammatory response around it, so it was removed surgically, and we can see the healing afterward. So this is one of the reasons that the writer suggests that we always use an MTA as an intracanal filling without the using of a 𝐏𝐚𝐵. What I like about Professor Yoshi is that he likes to think out of the box based on evidence and research. He gets deep in studying the mechanism of how things work to establish the most appropriate way of performing the procedure. What about the inferior alveolar nerve injury? The common causes of the damage of the inferior alveolar nerve is the local anesthetic injections, third molar surgery, implants, endodontics, which is extrusion of the material used in endodontic treatment, over instrumentation, elevated temperatures, trauma, and orthodontic surgery. The highest incidence of reported damage to the inferior alveolar nerve is associated with the third molar extractions. Local anesthesia was the second most common cause of the nerve injury. What are the signs that make us suspicious that there is a nerve injury? Severe pain during the procedure, high level of post-surgical pain, ongoing pain, altered sensation and numbness, functional problems, which means that muscular problems. We do a radiographic investigation to see if there is any material that is extruded out of the canal. We enhance the neurosense by to know if there is presence of any neuropathy and correlate it with a potential nerve injury and a diagnostic local anesthesia blocks. If the cause was a cut in the nerve, so a surgical bridging of the gap is important, and it must be as fast as possible. If injury to the nerve is ensured, we must initiate the surgical removing of the offending material within 24 to 48 hours via a periapical surgery or a tooth extraction or surgical debridement. If sensory improvement has not been evident after 2 months, with or without repair during intervention surgery, then the prognosis for recovery is poor. If no signs of healing are observed within 3 to 6 months, the chances of healing are considered much lower, although normal sensory function might still return after this time. Steroids may maximize the recovery of the peripheral nerve injury, and high-dose non-steroidal anti-inflammatory drugs, 600 mg of ibuprofen, also vitamin B complex and magnesium supplements may have some beneficial effects for neural recovery, Antibiotics are not recommended for nerve injuries unless infection-related neuropathy is suspected. We use the clonazepam intraorally to manage the severe gingival. Finally, let's talk briefly about the emphysema, which is defined as the penetration of air or other gases beneath the skin and the submucosa, resulting in soft tissue distension. The first recorded instance was reported in the 19th. It details that account of a musician was playing his bugle immediately after the extraction of a mandibular tooth. The subsequent swelling resolved a few days after he ceased playing the instrument. So he had an emphysema after playing his instrument that required his blowing inside it, but he did an extraction of the mandibular teeth before. So the tooth extraction, especially the mandibular third molars, remains the most commonly reported reasons of this iatrogenic event. Also using a high-speed handpiece reported to cause 66% of the cases. The majority of the cases present as a soft skin-colored swelling without redness and without pain. It happens shortly after the dental appointment. A crunchy feeling to the tissues upon palpation is an indication of the emphysema. That is usually palpated after several hours of the accident. An antibiotic regime is prescribed, and the emphysema has resolved and the tissue has become to a normal color and texture. Patients normally return to their normal appearance within 4 to 7 days. That's it. Salam. An iatrogenic event is defined as a procedure induced inadvertently by a physician or surgeon. Iatrogenic accidents can be greatly reduced with the aid of the 3 T's: training, technique, and technology. Sodium hypochlorite accident. The experience is likely to leave the patient wary of both the procedure and the practitioner. Sodium hypochlorite injection into vital tissues initiates hemolysis and ulcerations. It damages endothelial and fibroblast cells and inhibits the neutrophil migration. How to manage this accident? Local anesthetics and analgesics can be administered along with cold compresses in an effort to moderate swelling and edema. The clinician immediately irrigates the canal with normal saline to encourage bleeding, both dilating the irritant and removing it from the site of the injury. After 1 day, warm compresses are substituted for the cold and warm oral rinses are prescribed to stimulate the local microcirculation. Antibiotics are usually prescribed. Instrument separation. A common cause of instrument separation is improper use, which means inadequate access, overuse of the instrument, and the continuous use of a large instrument in a curved canal. The management. Tools dedicated to separated instrument removal, like extractors, wire loops, post-removal systems, ultrasonics, can be used. Ultrasonics can provide safety and accuracy in the process. The ultrasonic tip is placed on the staging platform between the exposed portion of the separated file and the canal wall, and it is vibrated around it in a counterclockwise direction. Applying an unscrewing force to the separated file, This technique will help with removing most rotary separated instruments that have a clockwise cutting action. Use in and out motion with a dry condition with lowest speed possible. Only after the loosening of the separated instrument is confirmed in preparation, the removal attempts can be made in a wet condition with the fluid to take the advantage of cavitation and aqueous stream. A DETAB solution or oil enhances the lubrication. The ultrasonic tip placed is continuously activated at a power setting that is about 5% higher than it was in the preparation stage, with short up and down strokes within the space created on the inner curve until the separated instrument is removed. Use of the loop. Separated instrument needs to be peripherally exposed by at least 0.7 mm to be grasped by the Yushi loop. The ledge formation. Reasons is failure to pre-curve the instruments, forcing large files into curved canals. How to manage. When a ledge formation is identified, the shortest file possible that can reach the working length should be selected to bypass the ledge. Original pathway is explored and opened up with the TFRK, this one. In short push and pull strokes, original pathway is widened with this instrument. Pre-curved straight ultrasonic tip can also be used here to reduce the ledge instead of this instrument. Orifice of the original canal can be efficiently widened with a pre-curved orifice opener rotary file. Then, a blue rotary file used as a hand file and the apical patency is established. Other methods are discussed in the chapter. Radicular extrusion of root canal filling materials. When 𝐏𝐝𝐻 is extruded into the periradicular tissue, there can be a severe inflammation reaction. However, MTA endosequence bioceramics are more biocompatible. MTA root filling extruded into the periapical tissues does not have to be removed. When 𝐏𝐝𝐻 is overextended into the periradicular space, removal can be attempted by inserting a new headstrong file, usually a 15 or 20, into the radicular obturation, using a gentle clockwise rotation to a depth of 0.5 to 1 mm beyond the radicular constriction. The file is then slowly and firmly withdrawn with no rotation, thereby engaging and removing the overextended material. Management of nerve injuries. Post-treatment radiograph should be re-evaluated to observe the possibility of an obturation material extending into the inferior alveolar nerve canal. Management should be performed by immediate removal of endodontic materials within 24 to 48 hours via periapical surgery, tooth extraction or surgical debridement. If sensory improvement has not been evident after 2 months, with or without repair during intervention surgery, then the prognosis for the recovery is poor. Vitamin B complex and magnesium supplements may have some beneficial effects for nerve recovery. Emphysema. Penetration of air or other gases beneath the skin and submucosa, resulting in a soft tissue distension. Tooth extraction, especially of mandibular third molars, remain the most commonly reported reason. It is pain-free. The patient takes antibiotics after 2 days of accident and the case resolves between 4 to 7 days afterward.